I can tell you that, here's an outline. I'm going to go quickly because I've been overly ambitious, I think, with the hour that I've been given to speak to you. And some of these things you're going to know a little about. I'll start on this side. What is borderline personality disorder? How is it diagnosed? How commonly does the disorder occur? What are some myths about BPD? I'm going to use that as an acronym throughout the presentation because it's just such a mouthful. How is it different than bipolar disorder? How can we use an evidence-based treatment called good psychiatric management, or GPM, to treat or meet the needs of BPD patients when they enter the emergency room? And so, many of you are probably familiar with this adage, but in medical school, I'm sure nursing school, pretty much in every school, you learn about the exceptions. The things that fall on either extreme of the bell curve. I was always more interested in what was falling right in the middle of the curve. The things that are really common that we see all the time. And so while a lot of my colleagues, a lot of my professors were interested in the zebras, I was much more interested in the horses. And so I think borderline personality disorder is a horse. And sometimes we get kind of confused. We overcomplicate things in our mind, and we start looking for zebras when actually the answer is right before us. And so one of the first myths that I want to bring to your attention is this myth that some people have in their minds that BPD is actually uncommon. And you've already laughed with me about that and realized that actually you're seeing it all the time, that it's extremely prevalent in your treatment setting. But just some epidemiology, so about 1 to 3% of the general population has BPD. Some estimates suggest that it's as high as 6%, which is much more common than many other psychiatric disorders. More common in women, though there's some literature that suggests that actually it's about equal in men and women. It's just much more commonly diagnosed in women. There are multiple reasons for that. One, that women are much more likely to present to a psychiatric clinic for treatment of symptoms than men. But certainly low socioeconomic status, age less than 30, and then indigenous peoples and African Americans, it's more common. This is always what comes to mind, I think, when we think about borderline personality disorder. That's the recurrent self-injurious behavior, the suicidal threats, the gestures, and certainly the increased risk of suicide. About 80% of patients will engage in suicidal behavior. Certainly when patients engage in suicidal behavior, there's a much greater risk of actual suicide attempt. And overall, it's about 50% greater than in the general population when we're thinking about the risk of suicide. It's very common in people who have actually completed suicide. The slide didn't come out exactly right, but there's a huge economic burden associated with this disorder. For a long time, we've often thought in psychiatry that it's actually psychotic disorders that carry the most economic burden. Recent data actually suggests that borderline personality disorder is on par with psychotic disorders in terms of the economic costs associated with having it. Another myth here. Patients with BPD rarely get better. I think this is really important because you're at the front line. So you're seeing these patients probably in kind of this revolving door, coming in, coming out, coming in, coming out. And I want to emphasize that even though you guys might not see these patients getting better, the data actually suggests that they do. There are complex reasons for why they don't necessarily, but you're probably seeing a lot of repeat visitors to the emergency room who have this diagnosis. Now, this is the data that we have for BPD, and this is looking at the longitudinal course of BPD. What you have right here on this axis, number of criteria. On the other one, it's the percentage of patients who have remitted from the disorder. So you can imagine that when you have fewer criteria that you meet, the number of remitted is going to go up. Looking at data over about 12 years, the average number of criteria that patients meet is 6.5. We need 5 of 9 criteria, and I'll review those with you later, in order to meet diagnostic criteria for BPD. With time, you can see that patients actually diminish the number of diagnostic criteria that they meet. At the same time, you see a commensurate increase in the number of patients who remit.
Are we done with the coffee thing, guys?
Yeah, thanks, Richard.
Yeah, I think so. Thanks, James.
Thank you, guys.
And so while we're not getting to 100% remission, we're certainly getting to a significant number of patients who have met criteria for the disorder at one point and then are actually able to successfully remit from it. That's not to say that they are able to return to normal psychosocial functioning. Many of them have long-term impairments, both in occupational settings and in relationships. Another myth, patients with BPD get better only if given extended, intensive treatment by experts. This has been a very common way of thinking about the treatment of BPD. So, I'm just a general psychiatrist, I don't have any extensive training in BPD, or I'm just a licensed clinical social worker, I didn't get extra training in BPD, I'm not really well suited to treat these patients. So you can imagine that creates one big problem, is that no one's then willing to treat these patients, which is part of why they rarely ever get better. People think of the liability, the risk, the suicidality. I don't want to take this on. Patients can sometimes be rather complicated in their presentation, which is just one more barrier to their getting care. What we've come to realize is that these are the myths. I've already talked about one, chronic, lifelong, unremitting. Not true. Requires experts to treat? Not true. Many patients will remit on their own. Now that doesn't mean that they're going to have easy lives. It might take years. Well, you saw in that graph that I just showed you that even after 12 years, a significant number, about 20% of patients, will still actually have the disorder. But many just need general case management. We need to think about not doing harm to these patients, and we think about how to interact with them. We've already talked about this. Significant number remit. This is also, I think, important. It's less relevant in your field because, again, you're having very abbreviated interactions with many of these patients. But I think something that can happen to any clinician who interacts with patients who have BPD on a regular basis is that sometimes you feel hopeless, disillusioned. Is anything that we're really doing even making any slight impact in the overall treatment trajectory of these patients? And what I can tell you is that for a long time, people thought, well, one, they don't get better, and even if they do get better, it doesn't last. So this is, again, looking longitudinally at patients who have BPD. And what you find is that once patients actually remit from the disorder, only a fraction of those are actually going to have a relapse. So if you can get a patient to remit, have less than 5 diagnostic criteria for BPD, the likelihood is that they're not going to have a resurgence of symptoms. They might still struggle with certain aspects of the disorder, but they're not going to meet full criteria. Okay. Sometimes we talk about patients being treatment resistant. Certainly with BPD, we can think about that. But this, I think, is, again, one common way of thinking, that patients are just very tied to their ways of functioning and not interested in getting better. Actually, you know this better than most people. These patients are commonly presenting for care. They're wanting help. 6% of PCP office visits, maybe as high as 20% of outpatient populations. At least a quarter of an inpatient psychiatric hospital has BPD patients on the census. And then about more than half of all the patients who are going to present into your emergency room with suicidality actually have borderline personality disorder. This is an interesting fact. I wish Dr. Kufler were here. When I interviewed, he said to me, I know you have this interest in borderline personality disorder, but I don't think we have enough of those patients here to really keep you occupied or interested in the clinical work. And I said, I don't have to worry about that. I know they're here. And I said, Dr. Snyder's here. He's worked a lot on the Down East Treatment Center. Maybe as high as 90% of the patients who are in medication-assisted therapy for opioid use disorder have borderline personality disorder. Okay. So thinking more specifically about your context, you already know this. They're high utilizers of emergency psychiatric services. They come repeatedly to the emergency room. We often use medications in ways to try to help patients that may or may not actually be helpful. They tend to get more medications than other patients while they're in the emergency room setting. And then you know this probably as well, that when you have these patients in the emergency room, they can cause a lot of stress for staff. They can cause a lot of tumult, chaos, and it can become an even more difficult work setting when you do have patients like that that you're trying to manage. So I want to back up at this point because I think we need to think about what exactly we mean when we're talking about borderline personality disorder. So I've labeled certain slides with stars, and so the reason I did that is so you can see how I work with these patients. All right. So one of the big things about using good psychiatric management is actually educating patients about the disorder. So I actually have several slide decks, and ultimately what I want to do is have everyone well trained and competent enough to do the kind of psychoeducation that this kind of treatment requires. And some of that is talking about, one, the course of the illness, the diagnostic criteria, the treatment, but also instilling hope and letting people know that people actually do get better and remit from the disorder. So when we think about personality, characteristic patterns of thought, emotion, and behavior together with the psychological mechanisms behind those patterns. What's a personality disorder? An enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to distress or impairment. This comes out of our DSM manual. There are 3 clusters of personality disorders. Cluster A, sometimes termed weird. Cluster B, wild. And then cluster C, worried. And so, we have several personality disorders within this cluster B category. Borderline personality disorder is one of them. More generally, we can think about borderline personality organization, which encompasses all of those different personality disorders. Okay. So this is what I go through with patients oftentimes to let them know what these symptoms are and how they get expressed. Fear of abandonment. So what you have here is an image of a patient, presumably in some kind of psychoanalytic treatment, lying on the couch. The analyst/therapist is absent. And you can't read this, so I'll read it out loud. The patient says aloud, "Well, doc, I guess I'm here to work through some abandonment issues." And sometimes that can actually be the experience of patients who have this disorder. Even though you might be heavily involved in their care, they might still experience you as absent or not present. Can be oftentimes very preoccupied about important attachment figures in their lives walking out on them. And sometimes that's a repetition of past traumas that they've experienced in their lives, not having supportive parents, etc. But this is kind of their internal world in which they feel kind of a dearth of caregivers in their lives. Unstable relationships, alternating between extremes of idealization and devaluation. I hate, I love you. Affective instability. In a way, this often gets experienced by people who work with these patients or have family members who are affected with the disorder, is this tendency to have to kind of walk on eggshells and meet their expectations, kind of anticipate what those needs are going to be, because if they don't, the effects can be kind of disastrous. Impulsivity in at least 2 different areas. So this could be excessive spending, dangerous or risky sexual liaisons, gambling, reckless driving, speeding, binge eating, substance use. People know what this symbol means? Say that again?
Catastrophe.
Semicolon.
Semicolon. Yeah, it's a semicolon, but it has a certain meaning within people who have experienced suicide in their lives. And so it means that it's just a pause, that it wasn't a hard stop. Oftentimes survivors of suicide might cling to this symbol or actually have it tattooed on their bodies in some way. And so with borderline personality disorder, I've already spoken to you about this very issue, that suicidality is common. The risk of suicide is greater in this population. Sometimes there can be recurrent suicide attempts. But there can also be non-suicidal self-injury, which is NSSI, and sometimes you can see that probably in the emergency room with superficial cutting, overdoses that weren't really overdoses, the intent wasn't to die. Inside Out, I don't know how many of you have kids or seen this film. Anger is a very prominent emotion in the young child's mind within the film. And this is how that gets represented through this kind of red and kind of angry looking character. I don't even know, it's square with arms and a tie. But inappropriate anger, difficulty controlling anger is a very common feature of borderline personality disorder. Chronic feelings of emptiness, very unstable sense of self. Sometimes I talk to patients about taking on the characteristics of other people that they're around, being somewhat of a chameleon, not knowing who they are within themselves and looking for others for cues about how to function or behave. And then this last one, during times of increased stress, people can actually become quite paranoid. If the stress is severe enough, this can almost take on a psychotic quality, which is sometimes why we think about the use of antipsychotic medications in patients who have borderline personality disorder. There is dissociation, which can happen with patients, so this feeling of not being in their bodies, losing time, seeing themselves from the outside, things feeling like a comic book, etc., etc. And so this is making the diagnosis. So this is the way that it's written in the DSM. Oftentimes what I do is I just go through the diagnostic criteria opening to page 665 in the DSM and reviewing each of the diagnostic criteria with the patients so that then they are aware and can make a narrative for themselves about whether or not these diagnostic criteria make sense, if they resonate with them. And oftentimes there's a lot of anxiety when you first start doing this because, well, one, no one likes a diagnosis, okay? But the interesting thing about this diagnosis is that people actually feel relief most of the time when they learn that they have something that's been well studied and empirically validated within the world of psychiatry. They know that I'm not alone, and actually there's a diagnosis that makes sense for the symptoms that I've been experiencing. Okay, and so these are those diagnostic criteria laid out as they're written in the DSM. Backing up, I've only had, I think, one experience with a patient who found that this was not helpful in the many patients that I've used this model with. Just again, thinking about suicide attempts, hospitalization, and decreased functioning, even when we're thinking about these 9 diagnostic criteria, actually just meeting one of these diagnostic criteria is going to increase the risk significantly for these outcomes. So it doesn't even necessarily mean that someone needs to have the full disorder in order to be at risk of having those things happen. So this is an area of controversy within the field. There are some people that don't believe in borderline personality disorder at all. They're very biologically focused and tend to think that actually everything is just the bipolar spectrum disorder. I think that's kind of one extreme way of thinking about borderline personality and bipolar disorder. I think there are important differences, and I'm going to list some of them here. So first off, bipolar disorder is not a personality disorder. It can co-occur. That's actually quite rare. Only about 10% of patients who have borderline personality disorder actually have bipolar disorder, or vice versa. The prevalence of borderline personality disorder is twice that of bipolar disorder. So when I hear patients talk about mood swings, the first thing I want to do is try to understand what those mood swings are. So are those things happening on a daily basis? Are they happening on an hourly basis? Are they precipitated by some type of social stressor? And those are all indicative of not of bipolar disorder, which is actually a persistently elevated mood lasting at least 4 days, if not longer, or persistently depressed lasting at least 2 weeks, because then we're talking about major mood episodes. But if I'm getting someone who's giving me a narrative of multiple fluctuations of mood, that to me is much more indicative of borderline personality disorder. Now, you're going to have patients who tell you that it's my bipolar acting up. I'm bipolar, my parents are bipolar, and it's really important to think about whether or not that's actually meeting this idea of what bipolar disorder is intended to actually describe. The other thing I'll say is that even amongst very well-trained clinicians, borderline personality disorder is commonly under-recognized, it's commonly underdiagnosed, and it's commonly misdiagnosed, usually as bipolar disorder. I think some of the reason this is done is because there's such anxiety about actually talking to patients about the diagnosis of BPD and labeling something bipolar disorder, because one, this is a marketing issue in some ways. Bipolar disorder is a much sexier diagnosis. Van Gogh had bipolar disorder. Well, maybe unlike Van Gogh, borderline personality disorder, what do you think of? And the way that it's depicted in movies and media, it's not in a very positive light. So in some ways, I think that's part of the anxiety and the stigma that we have associated with BPD. The other thing that I want to emphasize too is that the treatments for these disorders are very different. I tend to think about bipolar disorder as being a much more biologically based illness. It does not have necessarily much to do with what's happening in the interpersonal world, interpersonal stressors. It has much more to do with unclear precipitants that can lead to a persistently elevated manic episode or persistently depressed episode. When we think about borderline personality disorder, we're much more interested in the psychosocial world. What's happening socially that might be contributing to some of these symptoms? Let's skip this slide. Just emphasize to you again some of what I've tried to mention already about the differences. So, bipolar disorder, we're thinking about days to weeks. It can be long breaks between symptoms. So it could be that someone goes years and years and years without having another major mood episode. People are going to oscillate between poles of very high highs, elation, and very, very low lows, depression. Impulsivity occurs in both. But you're only going to see impulsivity in patients with bipolar disorder when they're in the height of a manic episode. It's not going to be a pervasive issue. It's going to be quite circumscribed. Unlike borderline personality disorder, where impulsivity is going to occur in the context of distress. So there's something happening in the social environment that's contributing to this increase in impulsivity. It's a much more pervasive problem. The affective instability, so the mood lability, the mood swings, that's going to occur over hours to days. It's consistent. It doesn't go away. Usually there's some kind of antecedent event, usually interpersonally, that's the trigger for the actual affective instability, and you're not having elation. That's not common, that's not seen in patients with BPD. At best, you're getting to this euthymic place, which is where, for a while in the world of mental illness, we thought that the thymus was responsible for our moods. And so that's where euthymia comes from, or dysthymia. So the euthymia is kind of this even-keeled, middle of the road kind of mood that most of us inhabit day in, day out, not depressed, not manic, somewhere in between. At best, patients experience euthymia. Usually they're experiencing some kind of persistent depressive state, and with stress or some kind of conflict, they'll experience significant anger. There are other differences. I already mentioned this briefly, medication response. Patients with bipolar disorder, medications are extremely effective usually. We have really good medications to manage the mood episodes that are associated with that disorder. Certainly there's going to be treatment resistance in every diagnosis, but patients who have bipolar disorder tend to respond to mood stabilizing medications quite well. Patients with BPD don't. Oftentimes you're going to get histories that involve maybe 10, 15, 20 different medication trials and nothing helped. That's one more clue that you have to keep in your mind when you're meeting patients who might be suggestive of having BPD. Relationship pattern. Patients with BPD struggle to hold down relationships. Usually there's a lot of chaos, difficult for them to maintain them. Patients with bipolar disorder oftentimes have more stable relationships that can then have tension or stress introduced whenever there is a major mood episode. Self-harm, you're not going to see that in bipolar disorder. So if you're seeing someone who's coming in with overdoses, frequent cutting, burning, head banging, those things are, again, suggestive of personality disorder. Alexithymia, again, the thymus, who knew it was so important? That's an inability to identify one's own mood state. So sometimes when you talk to patients who have BPD, they'll find it very difficult when you ask them, well, how are you feeling today? They might say, I don't know. Or oftentimes I get descriptors that aren't moods, they're just kind of adjectives. And then patients will follow up by asking me, is that a mood? Because they're very confused about their own internal feeling experiences and don't actually have a vocabulary to tie to what they actually feel internally. Rejection sensitivity is key. Some people argue that actually what patients with BPD are struggling with most in the world is being very interpersonally hypersensitive. So that means that they're very sensitive to criticism, very sensitive to rejection. And it's actually when those events happen that precipitate some of these other behaviors associated with the disorder. I've already mentioned this to you. This is just not true, unfortunately. Most clinicians aren't well trained in how to actually treat BPD, which is unfortunate for the patients who have it. I can't think of one population that is least well served by current mental health treatment. One, patients are often not diagnosed correctly, or they're misdiagnosed, or they're met with a treatment system that doesn't really want to take them on. Treatment of BPD is not done consistently or well. It's true that most clinicians actually don't like working with patients who have BPD, and there's a huge shortage of providers who are adequately trained to meet the needs of those patients.
Which is interesting, the numbers are so high.
The numbers are very high. So I've done my own kind of very abbreviated study of the patients that have been coming to me as new intakes and follow-ups as I've started at the behavioral health clinic. I did something similar in my residency. What I found was that about 25 to 30% of the patients that I was meeting in the outpatient psychiatric world at Maine Medical Center in Portland actually had borderline personality disorder. It may have been that they had never received the diagnosis despite having been in years of treatment, or they're coming new to the system, never having been in treatment before. What I'm coming to see is that we have something similar going on at the Behavioral Health Center. There's probably about 30%, so I did a little sequence. I looked at the first 32 patients that came to my office. About 10 of those had borderline personality disorder. Many of them had never been diagnosed. So this is a quote from John Gunderson. Patients with borderline personality disorder should be able to assume that the professionals who treat them have been trained to do so. So we have to have that same mentality when patients are entering through the emergency room system. We all need to feel competent in knowing how to work with these patients. They have the assumption that we know how to work with them. This is actually John Gunderson, who created good psychiatric management, which is the model that I'm going to tell you a little bit more about. So it's one of 5 evidence-based treatments for treatment of borderline personality disorder. It's essentially just based on American Psychiatric Association recommendations about how to work with these patients. It's a generalist model, meaning you don't have to be an expert. You don't have to be a psychiatrist even. Anyone can use the tenets in this model to work with patients who demonstrate symptoms of BPD. Its big focus is on psychosocial interventions. Okay? There's a very limited role for the use of medications in this disorder, and that is really highly de-emphasized using this model. Okay? Does not require specialized training. That's why I'm coming to you, because you can start to incorporate some of these principles in your everyday practice. And it's been shown to be just as effective in reducing self-harm, suicidal behavior, and emergency room visits, which is essential and something that we all need to work on as a system. And I imagine that so many of the patients that are coming through your doors have some element of this diagnosis. And so I want to just thank Victor Hong, who's a psychiatrist at the University of Michigan, who's done a lot of work about thinking about how to incorporate good psychiatric management into the emergency room setting. And so he and I had a nice dialogue last week, and he actually shared a lot of slides. He's been heavily influenced by folks at Harvard, where a lot of this work has been done and this model was created. And I really need to thank them, because a lot of these slides actually come from McLean Hospital. And so I'm going to just review what he has in mind about what we can take away from good psychiatric management and how to adapt it to an emergency room setting. So, I'm curious, I'm still learning how the system works, and I think this is what I've heard so far, is that you have crisis services available to you. So if any time there's a patient who comes into your setting, I think the triage is that you get crisis involved. I'm interested in hearing more about how things work here at MDI Hospital, since I'm still kind of a newbie.
Crisis and Acadia Telehealth.
Acadia
If
Telehealth.
we think that they're like suicidal or need inpatient management.
Yeah. And so, just backing up a little bit, so you have a patient, let's say, coming in, suicidal, you see the patient first as the physician or another provider, and then at that point is a decision made about whether to involve crisis or to involve Acadia, is that? And how do you make the decision about who to involve?
There's a debate. I mean, I personally, I feel like if I think that the patient needs inpatient psychiatric, if I'm concerned with the patient killing himself, I think that an inpatient, I'm calling crisis sooner rather than later. And I'm sorry, I'm calling Acadia sooner rather than later. And possibly crisis as well. If it's somebody who I think is just sad and I would get crisis involved and not call for telepsych. If I don't need help with med management, I don't think that they need inpatient management. I don't go down that road.
That's awful. Any other questions?
We do whatever they tell us to do. It's provider choice.
Well, the good news I think about what I'm going to share with you is that you can start, I mean, in some ways you don't want to take some of this on because I know you're already stretched thinly in ED, got a lot of patients coming in, and you know, psychiatric patients can often be pretty resource consuming. But you know, what I found in working with these patients in the emergency room setting or even in the outpatient psychiatry realm, I'll give you a little vignette. So there's a patient that I think we in some ways successfully diverted away from the emergency room. I was able to see same day, you know, late teens, early 20s, college student, female, who called the clinic one day expressing some vague suicidality. And I think there were thoughts about wanting to overdose on medication or something like that. That may not have been clear to me at the time. And luckily I had a same-day appointment available and we were able to get the patient in. There had been a lot of concern at her school about whether or not she'd be able to maintain her safety, and I think was raising a lot of people's anxieties about whether or not she was safe to be in the community at the present time. So I came into my office and you know, at first it was quite vague. I had difficulty giving me a narrative about what was contributing to some of this suicidal thinking, even planning or impulsive, intrusive thoughts about wanting to overdose on medication. And so, you know, what I did is I talked to the patient about, well, when did you last feel well? Okay, and so already I'm starting to try to create a narrative or form a narrative with the patient. And she was able to tell me, well, you know, things were going okay yesterday, but oh yeah, there was this thing, you know, I had this conflict with my boyfriend, and I said, oh, well, can you tell me about that? And so right away we're starting to think about the interpersonal world, okay? So these suicidal thoughts weren't coming from nowhere. There's something that had happened in the environment that was contributing to their onset. And so I said, well, can you tell me a little bit about the conflict? And she said, well, you know, he's not sure that he wants to be with me anymore. I really like him, and I'm feeling hurt by this. And he was actually telling me that he wanted to go to a party because he's interested in another woman. And he wasn't sure if it would make sense for me to go to the party as well, because that might put a damper on his possibilities of entering into a relationship with this other woman. And so I was really hurt by this. I was angered by this, appropriately. And so I empathized with her. But there was something else that happened later. You know, as she was starting to talk about the feelings that were coming up inside of her, being told about his plans to try to hook up with another woman, she started to get angry. She started to get upset. She started to feel hurt. And what did this guy say to her? Well, have you taken your medication today? Okay. So after that, where was her mind going? I want to overdose on that medication. I don't want to be on medication. I'm angry, and I'm going to show people how angry I am. I'm just going to take my medication, but I'm going to do it in overdose. I'll show him, I'll show other people. And so with that, we were able to put together a narrative, and within 30 minutes, we were able to think about the interpersonal crisis that led to the increase in suicidality. There was no need to change any of the medications. It was just a simple talking through and putting a narrative together about her experience that led her to leave this office safely. Okay? So connecting interpersonal stress with symptoms and behaviors leads to improved insight, and that's exactly what happened in the office. There was a moment where she's like, oh, now it makes sense to me why I've had these intrusive thoughts about overdosing on medication. Identifying a precipitating event, okay, can enable expeditious and reasonable disposition. That's exactly what happened in this context. So it's difficult to see from where you are, but this is the GPM, the Good Psychiatric management model really thinks a lot about interpersonal coherence. And so it's looking at these different kind of phases that a person with BPD can cycle through. Kind of in their best form, patients with BPD, when they're feeling held, connected, loved, they can be quite idealizing. And so they can be quite devaluing of themselves, but they can be quite idealizing of the other. They can be kind of clingy, independent. They can often experience this, persistent rejection sensitivity, so they're always prone to having kind of a fall from this position to one of these more difficult places. And so when we think about the role of interpersonal stress, so they've already got a vulnerability for being hurt, slighted, rejected. And when that happens, when they feel criticized, they feel rejected, they can actually get into this threatened place where they can become pretty devaluative, they can become angry, they can even engage in self-injurious behavior. And if they're doing these things to get the attention of the person that they really want to be with, what often happens is that that person doesn't want to be involved with them anymore. They actually withdraw, they leave. And that's extremely difficult for the patient with BPD because they're already so prone to rejection sensitivity. Not just it's going to communicate that people don't like me, they don't love me, I knew that all along. And so it can happen at that point, once there's that withdrawal of the other, they can get in this place where they get impulsive, they can be paranoid, they can get dissociated. And it's usually at this point when you're going to start seeing them in the emergency room. Okay, so they're looking for someone to hold them, to bring them back up to this place. It's not great, but better than either in this threatened or alone place. Now, if they don't seek out help, things can get even more severe. They can go suicidal. And so usually what you have happen is that there's a support that comes into their lives, involves some kind of rescue fantasy usually, and brings the person back up to this place. Oftentimes the cycle gets repeated over and over again, and with not an insignificant number of patients that can actually become overtly suicidal and engage in really risky suicidal behavior. This is a Taylor Swift model of that same interpersonal coherence model. I don't know very much about Taylor Swift, but